Hi all, and welcome to the afternoon lead-sponsored session. I'm just sneaking in here because Bob and I missed our opportunity to thank you all for joining for the 5-hour part of the conference today, and to remind everybody that we'll be online again at 9 a.m. tomorrow morning, and we hope to see you there. I'm now going to hand over to Bob to introduce this team.
Yes. So thank you for the whole day today. Those of you who are with us all day today, we look forward to spending more time with you for the Adherence Conference tomorrow, starting at 9 a.m. Eastern Standard Time. And thank you for joining us now for this Q&A live session sponsored by ViiV. This session is called Fast Track Cities for Implementation Science. We have a great group of people here who are going to lead this. And I'm going to turn it over to Ben Young, who will be the lead moderator for this. And Ben is the head of Global Medical Directors for ViiV. So thank you for doing this. Thank you for being here, everyone. And over to you, Ben.
Thanks, Bob, and thanks, Catherine. Again, I was not fortunate to be able to join most of this morning's sessions, but I trust, like previous Adherence conferences, it was wide-ranging and really informative and dealt with some important and sometimes neglected problems as we think about our response to the HIV and AIDS epidemics around the world. I'm also very pleased to be here on this panel today as a member of the ViiV family, but I think many of you will know that I have a long history with IAPAC and was a proud member of the team that helped launch both Fast Track Cities and involved with Adherence. So it's nice for me, a really hearty homecoming that I'm very pleased to be part of. I'm joined, of course, by the faculty of our symposium, and in no particular order, Carolyn Audet, Sarah Braunstein, Elvin Geng, and my colleague Maggie Czarnogorski. Excellent. I was able to watch the session, and again, really fascinating presentations from top to bottom. I very much enjoyed listening. And again, I think what is really quite special about this session is the linkage between the social behavioral sciences at Adherence, implementation science, and Fast Track Cities initiative, getting it done and trying to figure out, both from an academic effort, but also from a public health and public policy perspective. And at least I'd like to inject a little bit about, from the perspective of health and human rights, how do we actually end the epidemic? So I'm looking forward to a lively conversation. For those who are on the live audience, please feel free to enter your comments in the chat, in your chat session, and that'll be brought to our group for conversation. Maybe I can, just to get things started, can I start with you, Dr. Geng? And again, good to see you live. So in your talk, you talked about the various stakeholders and the actors and actions. How can you kind of interject then? How does this work today from the city's perspective, especially I think the learning lessons between established cities like New York and perhaps newer cities that or cities that have not even joined the initiative?
Yeah, thanks. Great to be a part of this conversation, and I think some really exciting discussions. One of the things that I think excites folks about implementation research is the idea of being able to draw lessons learned from very, I think, distinctive and unique settings to develop a sort of cross-cutting or general lessons. And so, when we think about the Fast Track Cities and the kinds of response that municipal and regional governments take, there's obviously this tremendous diversity, right? Each area has different capacities, has different strengths, has perhaps different organizations, and those organizations have different sort of native organizational relationships. And there are different levels of trust and engagement between public health authorities and the community. And so when we look from one place to another, it might appear to start with that, each place is completely unique, and therefore probably we don't have a lot that we can learn from one place to another. And I think that even though it is true that every place is distinctive, what we'd be hoping that implementation research can help us with is to develop some common ways of conceptualizing what's happening, even though there's a tremendous amount of diversity, some common ways of thinking about how one might measure those things, and then some common ways of thinking about sort of what these lessons learned could be, and then sort of using what's learned in one environment to help advance the response in another. Some of the stuff that I spoke about got a little bit into the weeds, and it was a bit technical, but I think that maybe the take-home message could be that the frameworks and approaches and perspectives have emerged and do exist that help us think about the implementation landscape in a sort of cohesive and systematic way, and that we could potentially apply these in very different settings to try to bring some sort of lessons across those settings together. I'm not 100% sure, Ben, that addressed your question, but just think that there's some exciting opportunities here to take advantage of.
Thanks, Elvin. I actually think it totally addressed my question. It's a really very broad question, but it's again looking for the sort of the cross-cutting relationships and where there's synergy between the various disciplines, whether it's public health, implementation science, clinical medicine, and so on. So again, I think this is what makes me so excited to sort of live in those intersectional spaces. Maybe that's a good way to segue over to Carolyn. You showed us this. You described your study in Southern Africa, and it was both an efficacy and with implementation endpoints. I'm going to allow you to speculate and probably just bounce ideas off. So what does that mean for cities, perhaps cities in the U.S. or other cities, as there are many cities in the initiative in Southern Africa? How does one go from where your data and bringing that to the public policy space, or even scaling up to implementing in other settings?
Well, I think the key component that we wanted to highlight in our presentation was that you can have an evidence-based intervention, but when you're doing it with a different population, often you have to sort of go ahead and retest things for fidelity and sort of make sure that any adaptations that you do still don't impact the intervention in such a way that it won't work in future. And so in our study, we're looking at, trying to get traditional healers to use PPE. And of course, in some, a lot of cities in Europe and the US, they don't have traditional healers. And so of course, it's not super relevant, but there are lots of other people providing healthcare, or there's unique populations in every community where you're going to have to take an intervention that's been done somewhere else, and you're going to have to do some adaptation. And as soon as you're doing some adaptation, you're probably going to want to test it for effectiveness all over again. And you're going to want to make sure that it can be done with fidelity, that it's acceptable and appropriate. And I think that's where implementation science really comes into play.
Maggie, to you, you're our VIF implementation science guru. Maybe I'll see Carolyn's commentary and kind of raise it one bar. You've had a distinguished career in the governmental sector, and now you find yourself in the private sector, and you've obviously seen the genesis of implementation science at the company. How does all this translate, and how do we effectively end our epidemics?
Well, thanks, Ben. Yeah, great presentations today, by the way. I mean, it's been a great opportunity to hear from all of you. So, I mean, like I said, we know that great HIV treatment exists, great prevention strategies exist, right? There's a lot of implementation strategies that have worked in certain sectors of the world, but now it's trying to understand how we can kind of implement them in different contexts and scale them to really try to end the epidemic. You know, we really do have a lot of the tools available to all of us. It's now, how does that work in all these different contexts to really try to optimize our processes around the world?
Thanks, Maggie. Elvin or Caroline, anything you want to add to that?
And sort of nothing in particular. You know, I think that's you know, well said, Maggie. I do think that in many ways, if you look across different fields that are beginning to embrace implementation research, I mean, it's certainly a way of looking at our public health problems that resonates with many different fields. I do think that the HIV public health response is in a unique place to sort of take things to the next level, because we do have so many highly efficacious interventions at our disposal, and we will have even more. And so, you know, I think that the sort of promise of the impact that those things could deliver is probably more tangible and real to us in this field than many others. And, you know, it's a great moment to be involved in this kind of work and to be, you know, excited about it.
Yeah, and I think it's interesting because, sort of as Maggie said, we have all of these evidence-based interventions, but you know, we have stigma when dealing with HIV. We have cost issues. We have different governments that have to buy in to get different treatments on board, or testing materials on board. And so you need to have people with degrees from sociology to anthropology to epidemiology to physicians. And that's what's so great about implementation science and HIV is it really takes a village to make this work, including buy-in from the community, and everybody sort of all the way along the path. And so hopefully sort of the steps that we have sort of shown to you today give you a sense of different ways that you can do that.
Thanks. I want to kind of, I mean, actually see your comments and maybe actually almost raise the challenge, right? So earlier this year, we heard data from Julia Marcus and with her analysis of the Kaiser Permanente cohorts that suggested that life expectancy for people living with HIV clearly is improving, as it has been for a couple of decades now. But moreover, that in people who are diagnosed with, you know, early with normal CD4 counts, that life expectancy is normal in a cohort of tens of thousands of individuals living with HIV in a large, complex country like the United States. And just this summer, the health ministry from Eswatini reported that they had attained 95, 95, 95, right? So we know, as Elvin said, that the possibility, the potential for normal life expectancy is there. The efficacy of our treatments is there. We know that at least from one small, very high burden, low income country, that attaining very high aspirational goals is entirely doable. So Sarah Braunstein, thanks for jumping back on. You know, at New York City, in a way, it was certainly not Eswatini, but it's another, let's say, geographically small jurisdiction with high HIV burden that has done phenomenally well with its HIV response. I mean, COVID-19 notwithstanding, what's your advice to, and I asked this question earlier to Elvin, what's your advice to newbie cities that might not have even wrapped their heads around the 2020 targets or have not began to endorse ending epidemics?
Sure. Thank you for that comment. I do think that the New York City experience, you know, we have more room to go, but has been quite successful. And I do think in large part it's due to just a few things that I'll mention among many factors. One, you know, we're starting from a place of having really robust systems. You know, we have infrastructure, we have capacity, I mean, which we've built over the decades. But, you know, a really robust surveillance system that can, you know, told us where we were when we were starting, that is able to be monitored, used to monitor progress over time, and to really course correct, use those data as we've gone to course correct. And I think, and to continually, and it's one of several data systems that we really have in place that, the triangulation of which really is helping us understand in which groups, in which geographic regions within New York City, which is, quite varied, albeit a relatively small geographic area, where we're making progress and where we have really room to go. And I really think that we have kind of married data and the evidence base with our programming in a way that has tailored the programming along the way, and in ways that we might not have expected 5 years ago, right? Just as we get closer and closer to, quote, ending the epidemic, and as our indicators, suggest better and better progress, we're using the data to understand where we need to be in our service delivery, in our programming, using community engagement as a tool to help us do those course corrections in a way that will be resonant and relevant to the people being affected. So I think it's a lot about infrastructure, systems, data, to tell us where to go and how we're doing. There's a ton of political will, I want to say also. We have high level support, both, in our governmental agencies, in the health department, at the city level, at the state level, support to promote and implement better policies that'll be supportive of our efforts, to fund the efforts, and just to also help us be innovative and disruptive in our approaches.
Thanks, Sarah. As a native New Yorker, I'm really proud of what New York City Public Health has done over the years, and I'm very, very pleased to have you on our panel today. We're coming up to our end. I wanted to see if Maggie, you wanted to have a last word from a VEEF implementation science perspective.
Yeah, thanks, Ben. Yeah, thank you all for contributing today. Your stories are inspirational about how we can use implementation science to really think about having that collective impact at the fast track cities level. Even I think there's a lot to be learned. Last year, in December of 2019, we sponsored a supplement to the JADES journal, and I encourage everybody on the phone to actually go take a look. There's 20, maybe 25 articles talking about great implementation science research on both a municipal, city level and regional level that I think can be really helpful as we start to think about how to do this in different fast track cities. And no matter where you are, whether you have great data collection systems or you're just starting out, I think there's opportunities to really use implementation science to help you start to achieve those 95 goals. So thank you all for your time today, and we hope that you enjoyed this session and look forward to talking to you more soon.
Okay, thank you all. Thank you for this great session as a tack on to our adherence conference, and a nice closeout to the day. So this is the end of the day for the IAPAC Adherence Conference and this Q&A session. Much appreciated, and we look forward to everyone joining us tomorrow morning at 9 a.m. Eastern Standard Time. We know that's various times throughout the world. We have a nice global attendance here, which is fantastic. And tomorrow we'll have another full day like we had today, starting with our Ryder Kaplan Memorial Lecture, and we have more tracks to present, more oral sessions. So everyone have a good morning, afternoon, evening, depending on where you are in the world. And we look forward to seeing you again tomorrow. And let me just tack on, as I said this morning, you'll make time. Those of us in the U.S. citizens, if you haven't already, please make time tomorrow to vote. See you all again soon. Thank you. And thank you to all of our tech people for keeping this going.